All right, we will continue on with our final hour of speaker presentation. And we are just so happy to have Dr. Nkanyezi Ferguson with us. She is a clinical associate professor in the Department of Dermatology at the University of Missouri. She serves as the Dermatologic Surgery Clinic Director and Micrographic Surgery Dermatologic Oncology Fellowship Director. She received her medical degree from the University of Missouri and completed her derm residency and fellowship in micrographic surgery and dermatologic oncology at the University of Iowa. Her surgical focus is on cutaneous oncology and surgical reconstruction. Her clinical and academic interests include general dermatology as well as skin of color and global dermatology. She previously served as the Director of Diversity, Equity, Inclusion in Graduate Medical Education at the University of Iowa. And she's also a former chair of the American Academy of Dermatology Diversity Committee. She's involved both locally and internationally in the medical community and in outreach clinics, serving underserved communities. And she has received the American Academy of Dermatology Presidential Citation Award and National Minority Quality Forum's 40 Under 40 Leaders in Minority Health Award in recognition of her work. I really appreciate her being here today. She's going to discuss dermatologic oncology in skin of color. Welcome, Dr. Ferguson.
Oh, thank you so much for the wonderful introduction. This has been just such an amazing conference, and I appreciate everybody for staying throughout the day for this last talk. So I will be talking about dermatology, oncology, and skin of color. I have no financial relationships or affiliations with commercial interests, and these are professional practice gap that I hope to address today. So for my learning objectives, I'd like to talk a little bit about the prevalence and presentation of cutaneous malignancies in skin of color patients. I'm specifically looking at basal cell carcinoma, squamous cell carcinoma, melanoma, and then also DFSP or dermatofibrosarcoma protuberans. Reviewing some of the current state of disparities in mortality and morbidity in skin cancer in our minority patient populations, and then some of the factors contributing to these ongoing disparities in our skin of color patients and strategies to help mitigate these disparities. So for basal cell carcinoma, when we look at the incidence in our lighter skin patient populations, we know that there's an incredibly high incidence and makes up about 75% of all cancers that you see in our skin cancers that you see in our white patient population. So you can see the incidence per 100,000 is anywhere from 212 to 250. For Hispanic populations, there's a pretty wide range of incidence, and this probably speaks to kind of the wide range of skin phototypes that you see within this patient population. So anywhere between 50 to 171. And then for your Asian and Black patient populations, that incidence falls very, very low. The risk association for basal cell carcinoma, we know for our lighter skin types, UV radiation plays a very strong role as far as risk association. We'll talk a little bit near the end of the presentation about, kind of risk factor stratification and what the true role is of UV radiation, especially in skin of color as a risk factor. Other things, scars, ulcers, chronic inflammatory areas, things that are a little bit more intuitive that will increase your risk for skin cancer. So albinism, patients with xeroderma pigmentosa, and then, recurring themes as far as our patients that are immunosuppressed and have reduced immunosurveillance that are increased risk for skin cancers. So what these look like, they're very consistent themes, between all skin types that, these tend to be, papules that have a little bit more of a pearly, kind of shiny appearance to them, especially if you're using a dermatoscope or have a light shined on an angle to the basal cell carcinoma. You can really see kind of a more prominent rolled borders that sometimes can be a pretty big clue to the diagnosis. But you'll hear again, kind of continuing theme that, there are more atypical presentations of skin cancers in our darker skin types. And so for basal cells, you tend to see more foci or globules of either brown, black, or blue pigmentation within a pearly papule. Kind of a black pearly description has been described for these. And in several cases, you'll see that the entire area is pretty deeply pigmented. And so when you're seeing these clinically, a lot of times you may have a more broad differential diagnosis, including melanocytic lesions on that differential as well. In your skin of color patients, you're going to see more pigmented variants in about half of all basal cells that you're diagnosing, as opposed to only about 6% that you see in your white patient population. Telangiectasias, although still can be evident and are still evident in these lesions, sometimes can be a lot less noticeable, especially for these really darkly pigmented areas. But when they are visible, really can help you kind of differentiate between more concerning melanocytic lesions. Just a couple of patients that have come through, just a very atypical presentation in skin type 5 to 6 patient on the foot. And I've seen, again, basal cells across all, skin types you can see in unusual places, but, in perianal areas where I've done surgery on these as well too. And then in a Middle Eastern gentleman over the chest, you can just see nice pearly pigmented rolled borders in that area. As far as distribution, is pretty consistent, across all skin types. We think about more sun-exposed areas in your lighter skin types. And then, I think it kind of questions the role of, kind of UV exposure, since across all skin types, you tend to see these in the head and neck region. Although, like I mentioned before, you can see them in atypical locations. For squamous cell carcinoma, the incidence is a little bit lower in white patient populations. Again, still a pretty broad range. And then, it kind of goes down from Hispanic and then your Asian and Black patient population, where it's anywhere from 2 to 3. When you look at the proportion of skin cancers in different racial and ethnic groups, squamous cell carcinomas represent about a quarter of skin cancers that you'll see in your white patient populations, but is a much higher proportion of the skin cancers that you'll see in Asian and Black patient populations, so about 65%. So this is probably the most common skin cancer that you will see in this patient population. Again, some of the same risk associations, and again, for squamous cell carcinoma, chronic scarring processes, chronic inflammatory conditions, chronic ulcers, are pretty big risk factors for this. So you'll see it in areas like, discoid lupus, areas of hidradenitis suppurativa, and so forth. Also thinking about HPV association, so high-risk HPV types associated with squamous cell carcinomas that you would more commonly see in the periungual, in the anogenital area, and especially in your immunosuppressed patient population and transplant patient population, you really want to be aware of anogenital squamous cell carcinomas that can appear and really have a high index of suspicion, and either evaluating and querying patients about any concerns in these areas. History of radiation treatment, and again, some similar things like albinism and XP as well too. So squamous cell carcinoma across all skin types are going to have a very, very wide spectrum of presentation. So anywhere from papules, plaques, they can be ill-defined, hyperkeratotic, ulcerated. So it really spans a huge gamut of things that these can look like. And I think makes it a little bit more challenging in diagnosing, especially in darker skin types. Pigmented variants do predominate. Just an example of squamous cell carcinoma occurring in more of an ulcerated chronic ulcer. You can see kind of this perilesional hypopigmented and hyperpigmented kind of molted look that you can sometimes see. And then across the spectrum, some of them will have more prominent erythema, especially in slightly lighter skin types. But in skin type 5 or 6, the erythema may not be very evident or appear more of a kind of violaceous color. And again, this is where we see a big difference in, kind of our risk factors and where this presents in our skin of color patients. And so usually lower extremities, the anogenital area, the most common places that you're going to see these as opposed to, very sun-exposed areas and in our lighter skin type patients. For melanoma, looking at incidence across all patient populations is slightly lower than our others more common non-melanoma skin cancers, but in white patients is about 26 per 100,000. In our Native American Alaskan natives, about 7.4. Hispanic patient populations about 4.6. Asian and non-Hispanic Blacks is much lower at about 1 per 100,000. And so melanoma again kind of shows the representation of percentage overall cutaneous malignancies, and so in white patient populations makes up in our Asian populations makes up about 10 to 19% and 1 to 8% in our Black patient population. And again, some very similar risk factors, thinking about immunosuppression, and then also potentially, patients with pre-existing pigmented lesions, especially on acral and mucosal regions, can develop melanomas in these areas. Clinical manifestations, and you look at a lot of codochromes of melanomas in our skin of color patients, and unfortunately they're pretty easy to diagnose because they tend to be pretty advanced in their presentation. And so any one of these pictures that you see, there's no question that these are atypical. They're larger, like multi-variegated colors within particular lesions. And again, you have ulcerated, so we know they're pretty advanced stage. But these again arise in non-exposed areas that actually have less pigment. So, about 3/4 of these are arising in your mucosa or palms, soles, or sublingual regions of our darker skin patient population. Very importantly, for your, nail melanomas, you can see the pigment kind of tracks onto your proximal nail fold called Hutchinson sign. And then for acral lentiginous melanomas, just something to be aware of, and definitely from, kind of a surgical perspective, these tend to have very significant subclinical, extension beyond, kind of your well-defined or your defined borders that you can clinically see. So in those cases, really thinking about your modality for procedural management, that you really want to choose a type of procedure that's going to have a, kind of comprehensive and complete peripheral on FOSS and deep, evaluation of your margins. And then also understanding that, you may need margins that are beyond kind of what your traditional margins are, because some of these can result in very, very large defects in your acral lentiginous melanomas on the palms and the soles. For melanomas, again, kind of shows the distribution in dark blue is what we commonly see in our lighter skin type patients, and then adding the acral areas to our skin of color patients. And then Hispanic men, the trunk is also a high risk site for these as well. So you want to be mindful in, patients that, have more pigment in the skin, that there is physiologic pigmentation, both of the oral mucosa and that you'll see in the subungual areas. In the oral mucosa, it's thought to be due to greater melanocytic activia, and so the gingiva is the most common intraoral site that has this pigmentation, and it can appear bilaterally, tends to be well demarcated. It can have like this ribbon-like kind of dark brown band that usually spares the marginal gingiva. They can appear as isolated patches and diffuse speckling, and you can see this pigmentation honestly in a number of areas of the buccal mucosa and the hard palate and the lips as well. And so again, being very mindful that we're evaluating these areas, but understanding, kind of what's, kind of physiologically normal versus what pushes you over the edge to, seeing more concerning areas. So if you have variegated, kind of more heterogeneous pigment, history of change, or all things to alert you to being a little bit more concerning. Longitudinal melanonychia, so the dark bands that you see, longitudinal bands that you see along the nail, thought to occur as a result of nail matrix melanocytic activation or benign nail matrix melanocytic hyperplasia. And these findings are pretty ubiquitous in your skin of color patients, especially your skin type 5 and 6. And so your clinical suspicion for melanoma has to be a lot more nuanced, in this patient population, and really involve a constellation of symptoms that you're looking for. When you have a skin type 1 or 2 or lighter skin individual that comes in with a pigmented band, especially if it, kind of reaches a size of 3 millimeters. In those patients, we have a very low threshold to do, biopsy of the nail matrix. Is a little bit more challenging, in longitudinal melanoma and your darker skin patients. And so, with thinking about melanoma, if it's only involving a single digit, so I'm much more reassured when I see multiple nails with similar bands. And thumb, great toe, or index finger, places that you can see melanoma if it's singly isolated. If you have patients have a personal or family history of melanoma, if it's developing and you're seeing this pigment in the setting of nail dystrophy is something I would be very concerned about. If there's an abrupt change or development, or things where there's widening or darkening, definitely keeping a very, very low threshold to need to potentially biopsy or work this up further or follow closer. And I showed before in the prior photo that had a pretty obvious sign of Hutchinson sign, where that pigment falls over onto the nail fold. But honestly, sometimes it can be really tricky in some of your, skin type 6 patients that come in. And so that, again, it has to be this constellation of symptoms that you're wanting to be aware of and not to miss. Dermatofibroma sarcoma protuberans, I put this up there. It's not a very common malignancy, although a lot of the dermatologists who've been practicing, it's not uncommon that these will come through your clinics. It only makes up about less than 0.1% of all skin malignancies. But what is important is that the incidence in Black patient populations is almost double that of white patient populations. As far as the incidence per 100,000. And I definitely, in my practice, I tend to see this type of tumor, very commonly in skin of color patients. We really don't know as far as, kind of what, risk factors, kind of play a role in who's going to develop these types of tumors. But what's important is that there are, kind of known disparities. It's hard because it's not a very common tumor. So, trying to get, real racial incidences and, like true measure of what these disparities looks like is challenging. But of the evidence that we do have, Black patients are, 1.7 times at higher risk for all-cause death compared to white patients. And Black patients have a 1.8-fold more likely to present with larger, more advanced tumors that may portend a poorer prognosis. So what these look like clinically, they tend to be red, brown, firm papules. They have small, like kind of multinodular protuberant nodules, and hence, protuberans is in the name. Very commonly, we see on trunk, shoulders, proximal extremities are the most common areas of location, although we've seen them come through on the head and neck area as well. You will sometimes see a pigmented variant in skin of color. So the pigmented variant of DFSP is called a Bednar tumor. It's really unusual and very uncommon. So we may see it a little bit more commonly in Blacks, but still only makes up, the Bednar tumor only makes up about 5% of all cases of DFSP overall. So you won't always see deeply pigmented types. And I think this should always be on your differential. And, when you're looking at keloids and diagnosing keloids, really keeping a high index of suspicion. If it doesn't quite, kind of fit that diagnosis, they don't tend to have more, kind of that really shiny, taut, appearance that keloids have. And again, has this multilobular, type of appearance, or more dermal, kind of deeper dermal, location as well. So just putting up, potential mimickers to, at least think about. And I think this is pretty broad because the DFSPs can present in a number of different, in different ways. But, the first one I showed was a keloid was one of my patients, and something that I thought about was just looked a little bit more atypical for keloids, but he'd had a very long-standing history, had similar lesions like this in other places, but I would have probably had a higher index of suspicion if he had just had this, kind of plaque that was grouped in this area. But thinking about larger dermatofibromas, sarcoid myoma in certain clinical contexts, and Kaposi sarcoma, all of these, again, which can can have a pretty wide, varied clinical appearance where there may be a little bit of an overlap with keeping DFSP and the differential diagnosis. This is a patient, is a 46-year-old Hispanic male that presented with a biopsy proven DFSP. I would say the majority of my consults that come in, or at least over half of them, are always patients that have had an attempted excision of DFSP with broadly positive margins that are now coming in for Mohs surgery. And so you can see his surgical scar over the right parietal scalp. But you can also see a couple of raised areas that are distant to this. And I wanted to point this out. We did biopsies in these areas, and all of it showed for DFSP. And these aren't, like a satellite or in transit metastases. This is all the DFSP as far as like how far it's extending subclinically. And these tend to go deep along the fascial plane of the muscles, and that becomes a very, very easy pathway for it to extend pretty broadly microscopically. And so you can see those two areas. A lot of times in management, I will get imaging. Number one, just to get a better sense of the extent of the DFSP. Also helps to know kind of what other services I may want to get on board, because these defects tend to be pretty large, and so I sometimes will work with our other surgical specialties to take the patient to the OR for reconstruction after. I think just remembering that, with MRIs, I think it does a good job at, kind of looking at soft tissue and at least where there's more obvious, higher burden of tumor, but it doesn't always capture, kind of microscopic extent. And so, interpreting your MRIs and imaging with a grain of salt that these probably do extend pretty far microscopically, that you can't always, that's not always evident on imaging. And so usually what I will do is do a central debulk of my DFSP, and I'll talk a little bit later that I do send that central one in for permanent processing to complete my staging. And then I usually, if the location allows, will start off with a 2-centimeter margin. Again, most surgery we always think of, trying to conserve, and there are definitely some areas where we may narrow those margins a little bit, especially on the facial area, but to show how much these really extend, past your, clinical appearance. And this is never what you want to see on your Mohs map for Mohs surgery, because that means it's a long day for your histotechs and nursing staff. But we did finally clear the patient after 3 stages and was seen by ENT for the closure. Just another patient, again, just kind of shows the kind of indolent and appearance of what these DFSPs can look like to begin with. And again, when we're doing the surgical resection, a lot of times we're going down and including fascia in our Mohs layer. And again, these tend to be extremely large types of defects and reconstruction. This was a Hispanic gentleman that we saw at our free medical clinic who had this long-standing history, 20 plus years of this growing, DFSP, which was incredibly large. We worked with orthopedics in this case, where we did a Mohs moat procedure. So we just took the outside and cleared the peripheral margin. They cleared the deep margin, including muscle fascia, and closed with the split thickness skin graft. This is about the one tumor in our National Comprehensive Cancer Networks, our NCCN guidelines, where they're very, very explicit about your treatment modality, that you're wanting excision with either Mohs or some other form of peripheral and deep en face margin assessment, where you can completely assess your margins. And so if you're biopsying these, really your next step is should be to send these for Mohs surgery, again, because of that very extensive subclinical extension. And to complete, kind of staging, get a much better assessment of these, of the area centrally, we will send for permanent pathology. And main thing that we're looking for in our DFSPs is for fibrosarcomatous transformation. We know that fibrosarcomatous transformation is associated with the metastatic risk of about 15 to 20%. So that has implications on, kind of our surveillance and, surveillance imaging. And so a lot of times we're bringing in a multidisciplinary consult, case discussion about, kind of what we're going to do for these patients and how closely to follow them as well. So I wanted to switch gears to looking at disparities in skin cancer in patients with skin of color, and kind of what the evidence is out there, and kind of where we stand currently. And I'll start off with a case presentation of a very sad case. Is an 81-year-old Hispanic male who was Spanish only speaking, came in with a family member, essentially came in with a 6-month duration of a very rapidly growing, just really necrotic, mass on his calf. He had significant, positive changes on review system. So it had weight loss and a lot of B symptoms associated with it. We did do an incisional biopsy. I mean, you can see after we remove the necrotic mass that, he has, kind of nodules that are adjacent to the larger mass, and had very significant palpable lymphadenopathies that had at least a golf ball size lymph node in the inguinal area that was palpated on clinical exam. Unfortunately, he presented right before the Christmas holidays, but we were able to arrange imaging and hemonc and actually treatment on the next day. But this just to show how rapidly growing this melanoma was. Just after 1 week wound check, you can see that he's starting to get even further in transit mets in this case. And so he had a PET scan that showed, again, widespread metastatic disease to bones, lung, liver, bowel, and his lymph nodes. He did receive immunotherapy, and I think, one of the really sad things about this case is that our institution had a number of clinical trials for our melanomas, but unfortunately the clinical trial that he qualified for did not have Spanish consents, and so he was unable to receive what we would consider the standard of care and access to kind of the most up-to-date clinical trials. He did still receive immunotherapy, but he, after 90 days, you can see how rapidly progressive, this melanoma is. And I mean, we used to see this, 15, years ago or so, before we had all the immunotherapy available. So it's really sad to see cases like this still, and with all the advances that are currently in place. And so we know that despite the lower prevalence of melanoma in skin of color patients, there's increased morbidity and mortality. There's a later stage of diagnosis. So these tumors in our skin of color patients have an increased tumor thickness that affects the patient's overall stage, and then also presence of ulceration as well. When you look at patients with melanoma across racial and ethnic groups, of those presenting with regional or distant metastases, I think these numbers are very humbling that, we see regional and distant mets in about 12% of white patients. And you can see this percentage and proportion increases that, 18% in American Indian Alaska Natives, 21% in Hispanics, 28% in Asian Pacific Islanders, and then about 34% in Black patients. And acral lentiginous melanoma specifically, which is a subtype that's overrepresented in your skin of color patients, is an independent negative predictor of survival. And there's just decreased efficacy of immunotherapy in the treatment for metastatic acral lentiginous melanoma. So still a lot of work to be done with this particular subtype of melanoma. And then we know when we look over time that, there has been overall improvement of melanoma mortality rates, and there's no question about that. But you still see these racial disparities in melanoma specific survival that are continuing to persist. And so for, more localized melanoma, this disparity persists along all racial minority groups. But very concerning when you're looking at regional and distant melanoma for Hispanic patient populations, there's continuing increase in this disparity of melanoma specific survival. And then when you look at melanoma, it has the largest survival difference of all cancers between Black and white patient populations, which is an absolute difference of 25%, which is very significant. When we look at basal cell carcinoma, it's really hard, just because they tend to be pretty slow growing tumors. And so outcome measures for basal cell carcinoma in skin of color patients is really poorly documented. There's one particular study that looked at, kind of cases in the literature, and this is, probably under, reported, but of the cases they found of metastatic basal cell carcinoma in Black patients, Of the 4 cases, 3 of those patients had pre-existing, pre-existing conditions. So 2 of those metastatic basal cells arose in long-standing venous stasis ulcer. One of them developed in a chronic wound. Interestingly, basal cell nevus syndrome has been reported, and across all skin types. But in, your skin of color patients with basal cell nevus syndrome, the expression of basal cell is diminished compared to that of, white patient populations with this syndrome, and probably owing to inherent photoprotection from melanin in darker skin types. So just showed that, kind of contributing impact of UV exposure and, kind of sunburn index in basal cell nevus syndrome patients. And then, any darker skin or skin color patient who's presenting with multiple basal cells, you really want to be thinking about ruling out basal cell nevus syndrome, because that's pretty uncommon. For squamous cell carcinoma, Hispanic and Black patients tend to develop squamous cell carcinomas, as we talked about, in anatomic locations that are more atypical, but in those locations are also associated with more advanced disease at initial presentation. So those are your pedal, your anogenital, squamous cell carcinomas, and then also those on the lower extremities. The data about squamous cell carcinoma specific mortality for Blacks and Hispanics, there's not a lot out there, but we know that it's worse when compared to white patient populations. The mortality rate really ranges, you'll see in the literature anywhere from 17 to 30%. But we do know that there's a disparity in the metastatic rates between Black and white patients. And then, just squamous cell carcinomas anyway that are appearing in scarring processes, which we know is a risk factor in our skin of color patients, have a 20 to 40% risk of metastases. And then the urology literature, you'll find, the penile squamous cell carcinoma cancer-specific mortality for Black men is 2.2-fold higher than for white men. This is a study that looks at disparities in non-melanoma skin cancer in Hispanic or Latino patients based on Mohs surgery defect size. This was a multi-center retrospective study using data from 3 major institutions in the Los Angeles County region. They looked at a total of almost 3,500 Mohs surgeries of basal cells, squamous cell carcinoma, and basosquame squamous cell carcinoma that were analyzed. And essentially you can see the difference. The gray is the basal cell carcinoma, and then the orange is squamous cell carcinoma with regards to the Mohs final defect size. And so they found that Mohs surgery defect size were significantly larger, about 17% among Hispanic and Latino patients compared to non-Hispanic white patients. So kind of inferring, potential for later diagnosis, larger defects in this patient population with these skin cancers. And so there's a number of different factors that we'll talk about, that are contributing to the disparities that we're seeing. There's a lot of challenges in early diagnosis, some of which we've mentioned as we're, kind of going through the clinical manifestations and more atypical, locations that these occur. So occurrence in more sun-protected regions, which is not usually what we, are taught or think about with skin cancer risk. Having a low index of suspicion, so not thinking about it in your skin of color patients and not looking in the areas that we see this, or trying our best to stratify which risk factors we have with the information that we currently have in the literature. And then, lack of awareness, and this goes from, lack of awareness from patients to primary providers to dermatologists, so as well of presenting signs. When you look at, and all of these factors can result in a delay of diagnosis. When they looked at acral lentiginous melanoma specifically, they have found that off the bat, about 1/3 of these are initially misdiagnosed. And the median delay in diagnosis was about 9 months. And when you look at the mortality rates, so the blue line shows that when acral lentiginous melanoma is correctly diagnosed, and the overall survival compared to when it's misdiagnosed, and you can see that the 5-year overall survival is significantly lower. And so some common themes of the talks that you've heard today is, looking at a patient's, social determinants of health and how this affects their access to care, and, how it ultimately affects, specifically in this talk, a patient's diagnosis and treatment for their skin cancer. But there's a number of socioeconomic factors, physical environment, health behaviors, healthcare, and the patient example that I gave where language barrier and health literacy, kind of also impacted it. And I think what's challenging for providers and physicians that 80% of an individual's health is essentially determined by what happens outside of the hospital and health clinic area. And so we'll go through some the things to try to mitigate disparities. But again, I think this is an issue across all of healthcare that continues to be an ongoing issue that needs very proactive solutions. And so we know that there's an equitable access to healthcare, and this can be a number of different things: insurance, status or type, poverty level, geographic access. And we know that patients of racial and ethnic minority are less likely to see a dermatologist, period. And we know that dermatologists and most surgeons are geographically maldistributed, with most practicing in areas that are near well-resourced communities and academic centers. And studies have shown that living near a greater density of dermatologists was associated with better outcomes for both melanoma and then also Merkel cell as well. And then how this inequitable access, affects care is that, specifically looking at melanoma, that there are longer time from diagnosis to when, a biopsy is done and a patient's diagnosed to when they undergo definitive surgery for stage 1 to 3. And they found that Black patients, the mean number of days is 23 compared to 12 days for white patient populations. Black patients, along with patients with Medicaid and lower incomes, were less likely to receive immunotherapy overall. And when patients did receive immunotherapy, they tended to be longer times from diagnosis to initiation of immunotherapy. And Black patients specifically, compared to whites, that mean time was 130 days, versus 108 days. And as we know, in melanoma, it can be very impactful, and patients' access to care needs to be very timely to ensure good outcomes. There's a lot of disparities in research, and it's hard to even interpret the research that's out there, because there's a lot of variability in how we're defining skin of color in clinical research, and tends to be really subjective and very inconsistent. And even the collection of that racial data or ethnic data and like bigger studies or databases, like for instance, like the Sears database that looks at like melanomas and other cutaneous malignancies, that sometimes when they're defining who falls into kind of a Hispanic ethnicity, we'll look at last name, and so you can see how that's like just fraught with a lot of limitations and selection bias. And then it's hard when you're trying to study a disease where there's already a very low incidence to really try and target to get the representation that you need. That there are challenges anyway, and you look at psoriasis, atopic dermatitis, where there's disparate representation within clinical trials, and so take a diagnosis that already is extremely uncommon, and that only kind of compounds that. And I think that shows a lot in acrolentigenous melanoma, that sometimes that type of tumor is not even subtyped, and so it's just hard to extrapolate kind of treatment, and we see that in how it's not as responsive to some of the more traditional immunotherapies. When you look at some of the trials that have been done of melanoma, one in particular was a phase 3 nivolumab plus ipilimumab versus ipilimumab alone. When you look at the patient cohort in that study, there were no Black patients, 1% Asian descent, and about 0.1% of Native American Alaskan Native. And so the patient populations aren't even represented in the clinical trials that are happening. And the Cancer Genomic Atlas cohort that has 1,100 cases, only 7 of those patients were Black patients with melanoma were included in that genomic atlas. And so there's a lot of historic, barriers to representation in clinical trials, kind of aside what I previously mentioned about incidence of melanoma, but there's a lot of historic mistrust in, being involved in clinical trials, a lack of access, geographically for patients or economically to, be able to access the resources they need. And these clinical trials tend to take place at much larger academic institutions. Lack of cultural competency in research design just showed the example of, our clinical trial where there was no Spanish consent forms. And then, lower kind of socioeconomic status that, again, is kind of just pretends a lot of issues in access. And so, there are challenges in identifying and stratifying risk factors. So, for my skin type 1 or 2 patients that come in, or my white patient population, I have a very clear idea of how to stratify risk factors for my patients, how concerned I need to be, how closely I need to follow those patients, where and what I need to look for. But it becomes a lot more murky with skin cancers and skin of color patients. And so I'll pause a little bit, to talk about the role or lack thereof of UV exposure in skin cancer in skin of color. And so Dr. Adamson, I think, did a great job in looking at both melanoma and then keratinocytic carcinoma, and looking at, what is the evidence out there of, kind of UV exposure and its risk to developing melanoma. So their group did a systematic review of the literature, and 13 studies met their inclusion criteria. And so this inclusion criteria had to have some way of measuring, UV exposure preceding the diagnosis of melanoma, and then it had to classify the cohort into, different skin types. So it included skin of color. Of the 11 studies that they looked at, and this is specifically with melanoma, showed no association between UV exposure and melanoma risk in patients of skin of color, which I think none of us are really surprised by, talking about, the atypical presentation in areas that tend to be very sun protected. The 2 studies that did show kind of maybe an association with mixed results. One study showed an association that was only actually seen in Black men, but not for Black women, Hispanic men or women, and surprisingly not for white men or women, who we know have the highest risk for UV associated melanoma. So it's hard to know what to do with that data. The other study did show an association between melanoma and skin color based on latitude between cities in Chile. But the cities in which the melanoma incidence was higher contained a significant proportion of individuals of Croatian origin that had skin types 2 to 3, which I think goes back to showing that you really can't lump people into, kind of one racial ethnic subgroup and make assumptions about skin type, because there's a very wide range of skin type. So the conclusion there again, that UV does not appear to be a risk factor for melanoma in patients with skin of color. Looking at keratinocyte carcinoma, so that's basal cell and squamous cell carcinoma, I just don't think we have the evidence out there, and we'll kind of look at these studies in a little bit more detail and kind of what were some of the limitations. But in this one specifically, they found 12 studies that met the inclusion criteria. I will say the big thing is that 8 of these studies examined that exposure or UV exposure as phototherapy, as their kind of only marker for what they considered UV exposure. There have been plenty of studies that have looked at, kind of therapeutic phototherapy, that it does not increase the risk for, melanoma or other skin cancers. And so we already know that, that there's probably not going to be an association there. And so of the 4 studies that showed an association between UV exposure and keratinocytic carcinoma, a lot of these were in East Asian populations. So, cohort in South Korea, Japan, Taiwanese population, and Chilean population as well. There were no studies, though, that looked at other population types, and so no individuals of African ancestry. So I think the conclusion from this study that I get is UV exposure may be a potential risk factor for the development, of carcinoma among our Eastern Asian, population, because that's just the evidence we have. But there really is a lack of high quality research to make additional definitive conclusions. And I really think a patient's, photosensitivity and sunburn index is probably the, kind of thing that's going to tell us the most about their risk, specifically for keratinocytic carcinoma. And so definitely something to consider, especially in, maybe in your skin type 4 patients, to still be, counseling about, sun protection from a reducing skin cancer perspective, but knowing that we have these conversations all the time because there's, additional benefit to protecting from the sun from a photo aging, pigmentary perspective as well. And so what's the evidence? The evidence overall of these two studies was low to moderate quality. And we can only make as good a conclusions as, as good of the evidence as we can put in. And so really pushes back to like, we need high quality, studies to then, make broad conclusions. And there's a lot of inconsistencies about how UV exposure is quantified and then how skin cancer and sunburn susceptibility. I know more about measuring UV exposure than I probably ever wanted to know, like kind of reviewing this study in a little bit more detail, but it's really not an easy thing to look at, kind of a UV exposure on a population or individual level. And so how these studies determine, kind of UV exposure type, you can see from the table, there's a number of different things that each of these studies looked at, and all of them are just a little bit different. And so when you're looking at a population and, kind of essentially ecological surrogates for population level sun exposure, they're looking at a specific time point at the latitude or ambient or kind of Earth surface UV radiation, which can be affected by a number of different things like altitude, season, time of day, or ozone column or cloud cover. Individual received doses of UV radiation. Usually you garner that through different types of questionnaires. And so asking about, kind of what your sun protective measures you've used in the past, how much time have you spent outdoors, what are, kind of occupations indoor versus outdoor. And then very importantly, what that time period of exposure is. So your exposure, as a childhood is, as significant, especially in lighter skin types for melanoma risk down the road. And so, for your larger databases that you have, they're really looking at, kind of more of these ecological, surrogates for population level sun exposure again, which is very difficult to, to extrapolate in a, kind of a meaningful way, but the best that we have. And very importantly, we need more objective measures to determine skin color. It's important to accurately define an individual's skin color because that's an important modifier of received UV radiation to determine your sunburn susceptibility, which again, you can't, garner by, grouping people into and making assumptions based on larger groups. And so we use a lot of proxies to define skin of color in clinical research. And a lot of you have seen this if you, kind of look through this data, and these tend to be very subjective and inconsistent. And so I think a lot of times we default to physician diagnosed skin phototype, where we kind of estimate the Fitzpatrick skin type based on either race or pigmentary phenotypes by visual assessment, which a true Fitzpatrick skin type really is how the skin responds to UV exposure, whether they burn or darken, and kind of along that range. And so just looking at a skin type, again, I think that unfortunately a lot of studies, kind of stratify it based on just that visual assessment. And then, classifying, and how we're interpreting, how we're looking at these studies where they talk about race, and you have these broad categorical assumptions that are made about skin tone that really is not a reliable surrogate for melanin index. There are objective methods to determine skin color that I think, best practices really are needed in clinical research to more accurately define skin of color. And so there are objective measures like colorimeters, spectrophotometers that tend to be pretty consistent and reproducible and really can help mitigate potential bias. But as you can imagine, these can be very time consuming and costly as well. But I think it's just one of the flaws in, how we're the information that we have and the accuracy of the data that we have out there. And so what are some strategies to mitigate disparities? The last 3 slides, I'll kind of talk through this. But, closing some of the knowledge gaps through targeted both patient and professional education interventions. And there's been a lot more conversation around this. I think this conference is a great example of, kind of talking about some of these things. But, looking at education of our trainees, so on the residency level, and really ensuring that folks have a very broad exposure to all skin types. and targeting educational material at the, practicing dermatology level. And that's, our journals having, a variety of skin types to represent a number of different conditions. Patient educational interventions that are presented in a very culturally relevant manner that addresses, both language and health literacy barriers if those exist as well. So teaching our patients is important, but also really involving our primary care and community organizations to really improve awareness and early detection and early diagnosis, which is the endpoint that we're looking for there. Diversifying our dermatology workforce and very specifically recruiting individuals with a desire to practice in underserved areas. I talked a lot, there's a lot of dermatology deserts in the United States, and continues to be a reason why access to care, especially in these patient populations, is an issue. Really helping to ensure equal access to healthcare that's relationship and community centered, and that given in a very culturally competent, targeted, data-driven, and comprehensive way. And with that, equal access to care. And again, this is very, very complex. And when they've looked at wait times for patients, they find that patients with Medicaid or non-commercial insurance have much longer wait times. So how can we normalize those wait times between insurance types in our dermatology practices? Having systematic, changes in reimbursement that could incentivize physicians to see and accept Medicaid. And we know that Medicaid acceptance rates among dermatologists, general dermatologists, tends to be pretty low and as low as 30%. And thinking about how we can harness, kind of the resources that we have in telehealth visits and telemedicine to really try and help increase accessibility and reduce overall wait times. And then making sure that we have high quality standardized, research and to help us identify what are those risk factors, how can we better stratify, our skin of color, patients and who's high risk and really who we need to follow very closely. And, think through, what's going to help in as far as treatment and really understand so we can have improved survival outcomes. And so I talked a little bit before about having adequate representation. I can't understate how important that is so we can more equitably and broadly apply the conclusions that our research comes up with, providing, and it sounds very basic, but providing, informed consent in multiple languages and making sure that, how we're describing and talking about these studies is able to really broadly be understood by a variety of health literacy levels. Using and harnessing really our community and community-based organizations to help with recruitment into these studies and having very thoughtful, proactive, culturally competent research designs. And so my key, takeaway points is that, there's a low index of suspicion and atypical clinical presentations that continues to make it hard, for diagnosing skin cancers and skin of color and delay in diagnosis and increase mortality and morbidity despite the lower prevalence of these. And the issue why I think it's important to talk about this. And then really needing further high quality standardized research to identify and stratify those risk factors. But I thank everybody for their attention and happy to answer any questions.
Thank you so much. I really appreciate the thoroughness of your presentation and the importance of examining every part of the body of all of our patients. As it's extremely important to catch those early stages of cancer, especially in our skin of color patients. Let's see, is Dr. Kanadia?
Yeah, so thank you for that talk, Dr. Ferguson. The first question that came up was, do you know of any skin cancer trends based on skin color rather than self-identified race or ethnicity? We are teaching the medical school curriculum and this came up. Thanks.
Yeah, I mean, I think that, goes back to, I think that there's a lot of inferences that are made by, kind of racial type and, so in, like African American, and I think this is the problem, right? That a lot of these studies don't stratify it accurately by skin type specifically. And then when they do stratify it, a lot of times those are maybe physician assessed, types of skin types. And so I think it becomes challenging, and that's probably the best that we can do is kind of inferring, within racial groups, kind of that broad range of skin types. But I think it makes it very challenging and really sad. I think that we don't have more in our literature to really show and speak on that more definitively.
Yes, Dr. Ferguson, I had a question regarding nail biopsies. When patients come in with a linear pigmented streak and they're extremely concerned about the potential, of an early aguilar-lentiginous melanoma, what's your status on doing a nail biopsy, and knowing that you had to advise them that it may distort their nail plate? Is that something you perform, or what is your position on that?
Yeah,
And it's sort of ambivalent.
Yeah, no, that's a great question. I think with everything, understanding, kind of where you need to be concerned, what tips you over the edge, and really having a high suspicion for acrolentiginous melanoma. I will say I have a number of, skin of color patients that come in with concerns, or they've been referred by their primary provider. And I would say in a huge majority of the cases, I can provide reassurance just by the clinical exam that there's multiple nails, that there's no significant history of change. And so in those cases, if my patient's concerned, or if I have any concern, then, I will take photos and, follow these patients pretty closely. And if there's documented change, either by color or by, I'll get measurements, or by width, that may push me over. If I have someone though who comes in and there's a very definite history of this has been changing, this has been getting darker and it's been broadening, we'll have that discussion. Do we keep clinically watching, or is the patient concerned and I'm concerned? That the implications of missing an acrolentiginous melanoma is very high, and I think kind of weighing that with the potential risk for nail dystrophy. I think there's, ways to try to minimize the risk for dystrophy, but always knowing that if we're biopsying into the nail matrix, that's a potential a problem. But I think it's not uncommon that I will sometimes do it. More so again in my lighter skin, patient populations where we talk about there is that risk, but it's important to rule it out. But again, I think understanding that it's a lot more nuanced in your skin of color patient population. So I don't do many nail biopsies and in skin of color patients, but I have done some. And again, it kind of has to be that weighing of what the risks are and what my concerns are. So yeah, and if I am biopsying it, I think it's enough of a concern that it's important to, and we've decided that the risk of dystrophy is worth the information that we will get.
All right, thank you.
All right, are there any other questions? Okay, well, we truly appreciate you being with us today, taking time out to share your expertise. And we truly thank you for being with us today. Thank you.